We can hear you in Athens.
Savannah can hear you.
We can hear in Albany.
Excellent. So we're going to go ahead and get started. So today is the only lecture in this semester that's actually just a lecture. There are cases. This isn't a case-based class. It's kind of like in the beginning of your other pharmacotherapy for ID, where you have a little, like, introductory lecture and then you went into all the disease state management. That's what we're doing today. I'll try to take a break in the middle because 2 hours of just kind of listening to someone talk can be incredibly mind-numbing. So I will try to keep an eye on the time and give us a little 5-minute break in the middle just so you can stand up and stretch and do whatever. So I definitely understand that a lot of you may not have an interest in oncology and you're looking at the rest of the semester going, oh, this is something I may not be that interested in, or why do I have to wait half the semester for this area of practice. With the increasing incidence of cancer and the increasing age and longevity in the United States, regardless of your practice setting and your area of interest, you're going to come across these patients. So if you're interested in a different area, maybe you like pediatrics, maybe like ambulatory care, if you want to work at a community pharmacy, you're going to interact with these patients. We want everyone to have a good understanding of the pathophysiology of cancer in general and the various treatment modalities, and a lot of this is moving to the outpatient setting. And with our increasing use of oral anti-cancer agents and more specialty pharmacies and more retail pharmacies getting into this setting, it's definitely permeating all areas of practice. So even if this isn't your specialty interest area, it's going to be something that you'll have to deal with. I also think that as a healthcare provider in your future career, you're going to have people outside of your area of practice asking you questions. So friends, family members, neighbors, other coworkers that are going to expect you to know some of this information, whether it's your area of practice or not. And it's your choice as to how you mix your professional and personal life. But I can tell you that, a lot of people end up getting questions about, medications and things for cancer patients in their general social circle, because it's unlikely you're not going to have somebody in your life if you haven't already that this affects, right? So with increasing incidence of cancer, we do want everyone to have a good baseline understanding. So that's why in the curriculum committee has kind of decided that this is the kind of content that you all need. So I just wanted to kind of touch on this. So over the next 2 hours, we're going to talk about the etiology and diagnostic requirements of cancer. And we're briefly going to talk about response criteria for both the solid and the liquid malignancies. But we're really going to spend the bulk of our time talking about the mechanisms of action and toxicities of various anti-cancer agents. Some of this is going to be repeated in brief during some of the disease state modules upcoming, but the expectation is that the material in this lecture you already know going into the rest of the sections. This is cumulative. All the other people who are going to teach in the oncology sessions upcoming that are adjunct professors were given these slides, had input on what content was in here, and their expectation is that you know this material. So they may touch on it, they may refresh your memory, but the expectation is that you're going to know this information going into the next disease state modules and supportive care modules. So I definitely wanted to highlight that. I also think it's really important as a pharmacist, if you don't know how drugs work or what their side effects are, physicians and patients lose trust in you really fast. So that's something I think just really definitely falls in our wheelhouse, and that's what the emphasis is going to be. So the exam material for this, I try to highlight what's most and least important as I go through, so please pay attention to that. This isn't going to be case-based for the questions off this section. It's going to be rote memorization, which I know can be fairly boring to study, but I highly recommend, obviously, for this exam and cumulatively, you just have to know this material. If that means flashcards or however you study best, this is basic memorization. So I know it's a little different from how the rest of the class goes, so I did want to point that out as well. So cancer is currently the second leading cause of death in the United States. We've known about cancer for a very long time, so the growth of cancer and especially solid tumors looks kind of like the cancer symbol that I've shown here. That's how it got its name. Cancer is obviously uncontrolled cellular growth, and it can spread through the blood and lymphatic system, which is how we get metastases. So cancer treatment over time has significantly evolved. The earliest record about a cancer patient was in 2500 BC. It's what's called the Edwin Smith Papyrus, and basically it translates to there is no treatment. They talk about patients with these masses. It's basically what we infer as breast cancer, and they basically say all these patients die and die very quickly. So we've known about cancer for a long time, but it took a long time for us to even start to have any sort of therapies. So in the 1800s, the surgical approach, we said, oh, there's a know about metastases and distant spread, that didn't really work, right? So we could cut out the tumor bulk, but all it took was a couple of cells that didn't get clean margins or that had already metastasized, and those patients still didn't do well over time. So then in the late 1800s, we discovered how radiation can negatively impact people by using it in bad ways, because humans are great at knowing how to hurt each other. So then we figured out, okay, we can use this in a good way. We can maybe, treat the whole patient and get rid of all of those random cells that we didn't know about before. But that had a lot of systemic toxicity, right? The radiation overall, while it can get those metastases, it has a lot of toxicities and problems. And it wasn't incredibly all that effective. It didn't cure people either. So then it wasn't until the mid-1900s where chemotherapy kind of came to the scene. And if you think about it, that really wasn't that long ago. So we've only been doing chemotherapy for about, 80 years-ish. That's not that long. And cytotoxic chemotherapy we're going to talk a lot about today. It's going to be one of the main focuses. But it also, had limitations. So in the 1990s, targeted therapies really came to the market. One of the first ones being imatinib, which is a BCR-ABL tyrosine kinase inhibitor. It made the Time magazine cover as the magic bullet to cure cancer. So at the time, it was like this huge thing, and now we're like, oh, okay, well, A is for one cancer, and B didn't really cure them. So it was this huge thing, and it was great, but it again, wasn't really the cure-all, obviously. But we have a lot of different targeted therapies now. We're going to touch on some of these in class, but they're really going to be reserved for the future disease state lectures because it's a little too much information for an introductory lecture. So you're going to get more of that in the upcoming disease state lectures. So I'm not going to spend a terrible amount of time on it today. And then in the 2000s, immunotherapy really came to the market. And again, it kind of had headlines of the cure for cancer. Okay, we're not really there yet, so let's roll. And the most recent immunotherapy is what's called CAR-T, or chimeric antigen receptor T cell, which is augmenting a patient's T cells ex vivo and then putting them back. And so that just recently came to the market with 2 specific products and has an explosion of ongoing research in clinical trials. So this is kind of considered to be the next wave in modifying patients' own cells. The cellular therapy is now a type of immunotherapy that's like the wave of the future currently. But as we've seen with previous waves of the future, they all have their limitations. They're not necessarily going to be the cure-all for everything. So kind of temper what you see in the media a little bit. So before we talk about those specific kind of interventions more in detail, we do have to just cover some background. So cancer can be caused by mutations, so activation of oncogenes and downregulation of tumor suppressor genes. We're going to go through that in detail in the next couple of slides. But it's also due to exposure to various toxins. So these can be actual direct toxins like chemicals. They can be drug products. So you can get secondary malignancies. You're exposed to chemotherapy, you cure your first cancer, and then years later you get another cancer from the mutations that you got from your chemotherapy. Same thing for radiation. Radiation can set you up to have secondary malignancies as well. And then viruses. Specifically, some lymphomas are associated with viruses. We know that head and neck cancer and gynecologic cancers and things like that can be associated with various viruses as well. So being exposed to specific viruses, toxins, chemicals, and radiation can set you up to have cancer, and that's a very important testable piece of information. The pathology of cancer is hallmarked by replicative immortality. So these cells do not die when they're supposed to for a variety of reasons. So sustained proliferation because of either activation of oncogenes or downregulation of tumor suppressor genes. So these proliferation signals are ongoing in an abnormal fashion, allowing the cells to continue to live and divide when they shouldn't. And that can be a target for our targeted therapies. Also, angiogenesis is the creation of its own blood supply. Invasion means the cancer cells are going to invade normal tissue and kind of take over, and then metastases is the spread to other parts of the body. An important pathologic feature of cancer is that it can avoid the immune system. And this is very complex, and we're not going to get into all the nitty-gritty details, but this relates to how immunotherapy and cellular therapies can be utilized to treat cancer. Is we have figured out how do cancer cells affect their microenvironment, what do they do to the immune system to evade it, and how can we overcome that? So what are they doing that's abnormal, and what can we do to overcome it? And that's where immunotherapy really comes into play. So based on the pathology, as we talk about each cytotoxic chemotherapy, targeted therapies, immunotherapy, should relate back to this and kind of make sense to you. So as I mentioned, carcinogenesis is a multi-stage process that can be initiated by chemicals, viruses, or physical agents like radiation. So where do you get exposed to these farms are exposed to certain chemicals. People who work in facilities with radiation, or nuclear facilities or things like that. People who work with things like hair dyes and other chemicals in factories can be set up to be exposed to these chemical agents that can then lead to cancer. Carcinogenesis is a multi-stage process, which I've listed here just in very brief. So just being exposed to a carcinogen doesn't mean you're going to get cancer, right? So I have to have multiple steps there. The growth of the abnormal cells has to be favored, converts to cancer, and then has to continue to have the ability to proliferate and evade the immune system. So a lot of things have to happen. It's not just the exposure until we have cancer. That doesn't really work that way. So the genetic alterations are key for the molecular basis of cancer. So proto-oncogenes being activated and tumor suppressor genes being inhibited, and then cell cycle checkpoints being overridden is something we're going to talk about in the immunotherapy part towards the end of the lecture, so keep that in mind. And then telomerase is activated. So normally as the cells divide and divide and divide, the DNA gets shorter and shorter and shorter. So the telomeres shorten, and eventually when they're short enough, the cell knows, okay, I've replicated as many times as I'm supposed to, I'm done, and then they die off. Well, if you have activated telomerase, you avoid that normal senescence, and you will have infinite doubling. So that's that replicative immortality that happens. And so that's something that can help kind of proliferate these abnormal cells as well. So oncogenes, these allow for excessive growth, right? Oncogenes, so they promote oncology, which is kind of terminology makes sense. So the list of oncogenes is something that is testable, so knowing which ones are oncogenes and which ones are tumor suppressor genes is something you should know because it makes sense with the pathophysiology or pathogenesis of the disease and how we treat it. So turning on abnormal HER2, EGFR, KRAS, BCR-ABL, BCL2 allows for the promotion of these abnormal signals and the excessive growth and avoidance of apoptosis. So obviously inhibiting these factors, so targeted therapies that inhibit these would stop the oncogenes, allow normal cell death. So proto-oncogenes can have a couple of different ways they can lead to the abnormal growth. They can have point mutations either within a gene or a control element that allows for the hyperactive or excessive stimulation of the proteins that allow growth and division. They can also amplify genes, so having multiple of the same gene can lead to more proteins and more growth. Or there can be translocation or transposition, so gene rearrangement is kind of the general term for that. So gene rearrangement can allow for abnormal growth, so the growth-stimulating proteins can be made in excess. So for example, BCR-ABL is an abnormal fusion protein based on a translocation that leads to the abnormal growth in chronic myeloid leukemia. So that's just one example. BCL2 is a very common oncogene in various disease states, including leukemias and lymphomas. And again, that is an oncogene that when excessively amplified or has point mutations leads to the excessive growth of these cells outside the normal. In contrast, tumor suppressor genes are the exact opposite. They normally encode for growth inhibiting proteins. So you want to turn on a tumor suppressor gene in order to stop the abnormal growth. So a dysfunction in a tumor suppressor gene, so if somehow cancer has been able to figure out how to downregulate these, that leads to the defective or non-functioning protein, so that it doesn't stop the uncontrolled growth. It allows it to just keep going and going and going. These are often in the literature called caretaker or gatekeeper genes because they repair damage and or signal the cell for apoptosis. So if you take that away, damage doesn't get repaired, apoptosis doesn't happen, and the cells just keep going. The most common tumor suppressor gene is P53. That's definitely important information. It's a very common and very bad prognostic signal if you have this. So P53 is a transcription factor that repairs problems in DNA, and if it can't repair it, it signals the cell for death. It says, hey, there's a problem, we can't fix it, you need to just die off before you cause a problem. So if you have abnormal or absent P53, the repair never happens, and the cell keeps dividing regardless of the problem that's going on, and so the cancer cells just keep going and going. So for those of you who are more visual learners, this shows in graphic form what I just said. So normal P53 either repairs the DNA or signals the cell for death. If you have abnormal or absent P53, those repairs are not made, and the cancer cell can continue to proliferate and divide. I already mentioned this earlier, but again, other than activation of oncogenes and downregulation of tumor suppressor genes, cancer also can create its own blood supply, which is called angiogenesis. This is common in our solid tumors. So as the tumor grows and grows, it's going to exhaust its supply. So it of making pro-angiogenic factors and allowing itself to create its own new blood supply, which can starve out the local nearby healthy tissues, which is a problem, of course. Pro-angiogenic factors include VEGF, PDGF, and TNF-alpha. And then anti-angiogenic growth factors are IL-2 and interferons, et cetera, that you'll see we tried to target in immunotherapy early on with very limited success. So we still have agents that provide anti-angiogenic growth factors, but really don't work that well, to be honest. And then invasion and metastases are just that, as it grows and grows and grows, it overwhelms the local tissue, and then it can break off and seed in new places in the body, and that's metastases. And so that obviously starts at a very microscopic level and then can grow. So you can have distant metastases that are small but then rapidly grow, which is why cutting out a tumor doesn't always work, right? Because you may not have quote-unquote scope at all. So thinking about hematologic cancers, I put the hematopoiesis kind of chart. There's a lot of these online. If you literally just like Google image hematopoiesis, you can find a lot of different graphics for this that are either more or less detailed. So if this is something that looks totally foreign to you, I encourage you to blow this up and look at it, or look it up online in your own time, because this is something you don't need to memorize, but you need to have a general understanding of the myeloid and the lymphoid lineage to understand the hematologic malignancies. So we have, again, myeloid and lymphoid lineages, and we can have acute leukemias, chronic leukemias, lymphomas, things like multiple myeloma, and then a lot of benign hematologic conditions like sickle cell and thalassemia that we're not going to really cover a lot in this class just due to time limitations. But there are a number of different heme cancers, and they all happen at a different point within this flow, right? And because of different specific mutations, oncogenes, proto-oncogenes, etc. And so leukemia is what we call liquid, these hematologic cancers are liquid cancers. So they don't have a mass, they don't have invasion and metastases, they're already systematically spread because they're in the blood everywhere. Now lymphomas and CLL can have nodal involvement, so lymphadenopathy, just because T cells and B cells, specifically your T cells, can be in your lymph nodes. So those patients often present with lymphadenopathy, and they can have quote-unquote tumor bulk from that. And they can also have involvement in the liver and the spleen, because as your blood is filtered through your liver and your spleen, they can kind of seed there and cause splenomegaly and hepatomegaly. So I did want to talk about lymphoid lineage. You can have quote-unquote bulky disease, but they aren't tumor masses the way you think of like a skin cancer or a lung cancer mass. It's in the lymphatic system, and that's where the mass can be. So I just wanted to differentiate between a solid tumor and the bulk of lymph tissues. So again, abnormalities can happen at any point in this process, and that helps us differentiate which type of leukemia or lymphoma someone has. And they're really classified by myeloid versus lymphoid lineage. Now we're going to talk about these in the sessions I'm going to do later in the semester as discrete diseases, but my disclaimer is they're not. So if you ever have a chance to go to what's called a tumor board and listen to a pathologist discuss a patient's case, it's fascinating. It's honestly way over my head with how granular it can get. But there are mixed lineage problems. There are people who have had one cancer and have kind of transformed to another. So it gets a lot more complicated in the real world and in some percentage of patients. But for the most part, patients are categorized as you have this type of cancer because here's where your problem is in this lineage. That's the vast majority, but it really is a little bit more diverse than that, but we're just not going to get to that level here because it's just too much information. Okay, so let's switch gears a little bit and talk about screening, diagnosis, and staging so we can get into the anti-cancer therapeutic agents. So screening is not available or necessary for every cancer and for every patient. The benefit of screening for cancer is you catch things early, which should then lead to better outcomes for patients. But there are some problems with screening, right? Why don't we just screen everyone all the time for everything? Well, obviously it's cost prohibitive, that's not going to work. But also overdiagnosis and false negatives lead to excessive treatment and intervention, which of course would not be good at the patient level either. So we really have to balance the benefits to the risks, and the CDC and what's called the USPSTF, or United States Preventive Services Task Force, have recommendations based on data. So this changes quite frequently. What I learned in school, what I learned as a resident, and what's happening now are three different things. So I'm not going to test you on this page or the next page, because it's probably going to change by the time you practice anyway. Now, if in a future session another faculty wants to teach current recommendations for that cancer, then by all means do what they say and study that they tell you to. But for the purpose of this session, I'm not going to tell you, oh, which age group needs screening at what interval. Like, you can look that up. You don't need to memorize that. You just need to know that there are guidelines, and if you're asked, you history of heavy smoking or are put within the past 15 years. That's the current recommendation. So I just wanted you to be aware of that. In your DePiro textbook, they have a table that talks about at what age group and how often for all of these cancers. But there are some differences in various guidelines for some of these. So again, I don't feel like it's testable information. You should just be able to know where to go to look it up and understand that most screening is for solid tumors. And so I just wanted to touch on that, but we're not going to go into super detail about it. The diagnosis of cancer, so anybody ever kind of gone to WebMD or had a family friend or someone go to WebMD and it's like, you could have this, or cancer. Like every time, right? And doesn't matter what you put in, you just have the common cold or cancer. You have an infection or cancer. It's always on there. And the problem is there's so many different cancers and so many different presenting signs and symptoms that could happen that it's always, it could be cancer, right? And I'm not making a joke. Like honestly, every time you go to WebMD, it's going to say that. So it's hard to say like what are the most common signs and symptoms. It depends on the cancer. As we go through each module, we're going to talk about for that disease what are the common signs and symptoms, and those are important. But overall, I've listed some that some general references will say for adult versus pediatric. So obviously for solid tumors, so like skin cancer or breast cancer, you might have a lump or a lesion. For things like GI cancers, you probably have change in bowel habits. Bleeding, fatigue, night sweats could be a leukemia or lymphoma, because those are things that happen when you are myelosuppressed or have low myeloid levels. Pediatrics, a lot of these relate to signs and symptoms of acute lymphoblastic leukemia or ALL, which is the most common pediatric cancer. So again, low blood counts can lead to fatigue, bruising, infections. They can have hepatosplenomegaly. So I know it's varied. I'm not going to test you on that, but I just wanted you to realize that why is there such a long laundry list of all the different signs and symptoms? Because there's so many different cancers and they all present differently. Now, overall, to diagnose cancer, you have to have a tissue sample. So for solid tumors, they do a biopsy. So they're going to cut a piece out and look at it in the microscope with a pathologist. For some cancers, specifically like lymphomas and other things, you can do what's called an FNA or fine needle aspiration. That's kind of gone by the wayside because you really need slices of tissue to look at. So we don't do that hardly ever anymore. But for the heme malignancies, you need a bone marrow biopsy. And I just, so that you know what it looks like, put a graphic representation. They do put patients on their side, and they go into the iliac crest with a very large needle, and they suck out some bone marrow in an aspirate, and then they look at that under the microscope and can run cytogenetic and molecular testing off of that. So for heme malignancies, that's the test. I have one little caveat here. So the only cancer that you can start treatment before you have a definitive diagnosis is acute promyelocytic leukemia, or APL. It's a specific, very rare subtype of AML, but if you have suspected APL, it is not inappropriate to start chemotherapy before you have a diagnosis. So that sounds like crazy, right? We would never do that for anything else. But the treatment of that, which we'll talk about in my AML lecture, is ATRA, or all-trans-retinoic acid, which is an oral pill. And if you don't have cancer, taking it is not really going to hurt you that. I mean, it's not going to do a whole lot. But starting treatment early for APL has improved outcomes. So it is the only case in which you can dispense a chemotherapy agent before having a diagnosis of cancer. Otherwise, as a professional, you should always double check and make sure that they have specific documentation by a biopsy of whatever cancer they're treating, because otherwise it would be malpractice and you don't want your license on the line there. So I wanted to point that one out because we have had people call, a pharmacist in our central pharmacy or the retail pharmacy that say, oh, I don't have a diagnosis, the physician says I should dispense it anyway. As the oncology person on call, always like, yes, send it, it's fine. We need to give it to him immediately. So that's just a caveat that's very rare, but I wanted you to be aware of it. Question? Do you mind repeating?
Could you repeat what ACL stands for?
Yes. So APL is acute promyelocytic leukemia, and it's a subtype of AML, which is acute myeloid leukemia. And we're definitely going to talk about it again in my AML lecture, but I do want to point it out here because I think it's something that if you're not told, you can actually delay effective treatment and it would have negative outcomes on patients. So that's why I pointed it out.
Do you mind repeating the drug name too?
Yeah, and the drug name was ATRA, A-T-R-A is the acronym, and it's all-trans-retinoic acid. And it is an oral pill. Okay, so talking about staging and workup, each cancer has different staging and different workup, so I'm only going to provide some generals here just so you kind of have a lay of the land. For solid tumors, they're staged by what's called the TNM system, tumor node metastases. I'm going to repeat that. TNM stands they correspond to staging 1 through 4, so good to 2 worse. Staging obviously correlates with prognosis, that's why we do stages. So early stage tends to have better prognosis and later stage has worse prognosis. Staging for heme malignancy, since they're already systemic, TNM doesn't count, right? Because there are usually no tumor bulk and no metastases already out there. So they each have their own staging system to make it complicated. So we're not going to get into that. Working up a patient usually involves all the various labs. So a lot of solid tumors have cancer markers. They can have scans like PET scans, CT scans, MRIs to look for tumor bulk and size them, to look for metastases. And then performance status and organ function are really important in the workup because that dictates what treatment can you give a patient. Some patients aren't eligible for certain treatments because they have poor performance status or poor organ function. And we're going to talk about that in each subsequent session as well. So I'm absolutely not going to test you on the next 3 slides. They're examples. I just want you to see what it looks like, but please do not try to memorize any of this. It's totally unnecessary. Again, you can just look it up. So here, I just took the NCCN guidelines, which you're not supposed to do, so a TNM. So what are all of the primary tumor descriptions? What are the node ones and what are the metastases? And so how does this correlate? So for non-small cell lung cancer, when you look at each T, N, and M for various patients, you would have to define what category they're in. So, stage 4B, you can have any size tumor, any number of nodes, but you have an M1C for your metastases. And again, you have to go back to the T and M to know what that is. But this is all diagnostic. You just have to have a general understanding. You're never going to do this as a pharmacist. You just have to generally understand what it means. Same thing for heme malignancy. So I said each one has its own diagnostic kind of workup. So Hodgkin's lymphoma was one of the easiest, so that's the one I picked to represent here. So it's based on the size of your disease, so that lymphadenopathy, the number of nodes that you have, and then your ESR rate, and then that correlates from stage 1 to stage 4. But in addition to your general staging, they also have a scoring system for prognosis, and the number of scores points to a prognostic indicator, and I've just listed what they count up here for that. So sometimes you have staging, and then you have a scoring system to give you both to decide what your patient's overall prognosis looks like. Again, do not memorize any of this, they're just illustrative. What is also important to understand is performance status. As I said, when you're reading a chart, knowing what their ECOG, which is Eastern Cooperative Oncology Group, and Karnofsky scores are, they may report both, they may report one, it doesn't really matter. It's indicative of how functional is your patient at baseline. So ECOG 0 is hopefully all of us. We're up and doing our own ADLs, we're taking care of ourselves, going to work. And then a Karnofsky of 90 to 100 is correlative, so again, normal patient. And then 5 for ECOG and 0 for Karnofsky is dead, so they're inverse of each other, which is important to realize. So 0 to 2 of ECOG and about 70 to 100 of Karnofsky is typically what's eligible for clinical trials, so that's quote-unquote better performance status. Anything below that is generally considered poor performance status. So if you open a chart, you see someone has an ECOG of 4 or a Karnofsky of 40, you can kind of just off the top of your head already know, ooh, they're not doing so well, they're probably not going to get intensive interventions because they're not able to tolerate it. So it just kind of helps you put in perspective what their options might be. So you don't have to memorize these numbers, but in general, knowing which way the scales go and how they correlate to each other, I think is really important for you to understand. Because if you open a chart and someone's Karnofsky is 30, and you go around and start talking about intensive chemotherapy, everyone's going to look at you like you're crazy, because you're on. So it just kind of puts things in perspective. All right, so that was, a good 30 minutes of background information. So now let's get into the pharmacy part, the meat of what we're doing. That's the anti-cancer agents. So how do we give these? I've already talked about we can give oral agents, and then obviously a lot of them go through the vein. So most agents need to go through what's called a central line, so it goes directly into a high flow vessel. So this can be done via a peripherally inserted central catheter or a PICC. A Hickman is a type of central line. So again, these are kind of like tunneled underneath and go into a larger vein versus a little, if you've ever been in the hospital, you already have a little peripheral like hand line put in. You can't put a lot of chemotherapy through those because they're caustic, right? They're dangerous chemicals. You put them in a tiny little vessel, a lot of them are vesicants or extravagants, and they're going to damage that tissue or that vein. So we have to put central lines in most of our patients. I just wanted you to be aware of that, because these patients then have to take care of their line and not get infections, and that's a whole other patient care problem. A central port is implanted under the skin up in the clavicular area. So it's kind of a subcutaneous device that then they access via a needle, and the chemotherapy can go through there, and then they pull the needle out, and the port stays under the skin. So those are some works just like a central port, but into the CSF. So then they can just easily inject into the little port in your head rather than have to do a lumbar puncture. And this is for intrathecal chemotherapy. So if we need to deliver chemotherapy directly to the CSF for patients who have either primary CNS lymphoma or CNS spread of their leukemia, you can give them a lumbar puncture every time, but some patients that have to repeatedly get this, especially pediatric patients, that's not comfortable for them. They would rather actually just have a little port in their head and have the needle put in and out every time. So that's one thing. So if you see patients with a kind of a bump there, and a patch, that's probably what you're looking at is in the Maya. So that's a picture of it up at the top. And then intraperitoneal or IP catheters can be used for gynecologic malignancies, and any patient with normally like a GI malignancy that has spread to the peritoneum. So that allows us to put chemotherapy in the peritoneal fluid. And there are some side effects to this. Patients don't always tolerate it very well, but it does increase their outcomes by being able to deliver, again, the chemotherapy directly to the site of the cancer in the peritoneum, in the CSF, where normally, getting things from the blood into there may not be good penetration. So it's kind of like your direct method to inject. So those are just terms I wanted you to be aware of. Okay, so talking about tumor growth. Thankfully, all of us are exposed to carcinogens here and there. So our normal immune system can kill off the very small amount of cancer cells. Now, if you have a weakened immune system, obviously that's a problem to be able to not be able to do this. And then if your cancer is able to evade the immune system, that can kind of be a problem. But in general, small amounts of cells are normally routinely eliminated by the immune system. The problem is, as more and more cells get there, how do we get rid of them, right? And eventually, our immune system isn't enough to keep it in check. So we have to provide outside therapies like our chemotherapy. Now, the tumor kill hypothesis is based on our understanding of Gomperzen tumor growth. So basically, when you have a large amount of tumor bulk, every chemotherapy only kills off a percentage of it. So as you kill off more and more and more, you're still not, even though you have a quote-unquote small amount of cells left, you're still only killing a percent of them. So you give more chemotherapy, you don't kill off everything that's there. So no cancer is like one and done. Hey, you got your chemo, you're cured, move on. That doesn't happen. And it's because we only kill a percentage at a time, and that's why our therapies are currently so limited. So here's just the verbal description. The next slide has the graphic again for the visual learners. So there's been mathematical models that approximate the tumor cell proliferation and therefore how much cell we can kill with chemotherapy. So early on, a lot of tumors have really rapid doubling time, so we can kill a percentage of it, so we get most of it. But there's some left, right? And that can regrow and cause relapse or refractory disease. Tumors can outgrow their own blood supply nutrients and autolyse. You can have some tumor lysis just from the cells overdoing it so fast that you just don't get enough nutrients in the blood supply. That can happen as well. And then how long does it take for a cancer's doubling time and how rapidly does it progress? Depends on the cancer. There are some, again, that are so fast, like Burkitt's lymphoma and aggressive non-Hodgkin's lymphomas, that exhaust themselves. These patients come in tumor lysis because their cancer is literally outgrowing itself. That's how fast it's growing. And there are other more indolent things like follicular lymphoma and some skin cancers and others that are really slow, or chronic myeloid leukemia that can be a more slow doubling time. So each cancer is a little bit different, but this is a generalization here for you. Again, this just kind of shows a nice graphic representation out of your textbook about how cancer can start and be kind of kept in check by the immune system, and if it keeps going, they then can physically see it and catch it, and then we have to give our interventions to try to continue to kill off as much as we can, but realizing that anti-cancer agents, no matter what it is, don't kill off all in one shot. That's just unfortunately not how it works. Some of this should be review, I hope. If it's not, please definitely go back to your book chapter and read this to make sure you fully understand it. But this is the basics of your cell cycle. So G0 is your quiescent resting phase. G1 is where you're synthesizing your enzymes, getting ready for synthesis. S is where you double the amount of DNA. G2 is where you synthesize all your DNA, but your protein and RNA synthesis continues, and your microtubule precursors are getting all set up to produce the mitotic spindles. And then the M phase is mitosis actually occurring. It can separate into its two daughter cells. So this is important because we're going to talk about some of the anti-cancer agents that are cell cycle specific. So where are they specific in here? So we're going to talk about that. So why do we care whether it's cell cycle specific or non-specific? clock. Like, oh, we're all going into apoptosis now. Like, that doesn't happen. So they're all in a different phase at a time, right? So if you give a drug, and it's cell cycle specific, you're only going to get the cells that happen to be in that when you're giving it. So how can we overcome that limitation? We give these drugs more frequently or continuously, because then you're going to be able to hit more and more cells in that part of the cycle, right? Versus if you're cell cycle non-specific, it's more dose dependent. You don't have to try to target the cells in a certain area, right? Because it doesn't matter. So then you want to give more of a dose to hit more cells. So whether we do higher doses or whether we do continuous or more frequent administration should depend on how it works. And you're going to see that in the regimen. And by and large, we're not going to test you on doses or administration because, again, you can look that up. But, well, okay, so for some oral drugs, we are going to test you on that. We'll point that out later. Disclaimer. But in general, we need to realize, well, why does it matter that we know this? Because it makes sense with how we give the drugs. And so if the physician wants to do something different and ask why, you can really rationalize with them, understanding the mechanism. And then we're going to talk, after we talk about the cytotoxic agents, about the biologic and targeted therapies separately, which talk about more about cell signaling and not the cell cycle. So that's kind of our next chunk once we get through this. So here's just one image of visually where some are cell cycle specific and where are cell cycle non-specific, which is CCNS. That's a common acronym, just so you're aware. So we're going to go through these now in detail. So this just reflects what I just said about administration of either dose dependent for non-cell cycle specific, and then schedule dependent for cell cycle specific.
Is that a call? Yeah.
Again, for your visual learners, I have some graphics. Feel free to kind of blow this up and look at it. If you're kind of more of a visual person for where drugs have mechanisms within the cell cycle or outside the cell cycle, but all of this is in the future slides. It's just graphic representation for those of you who may be interested. Okay, so we're going to go through each category now. So antimetabolites are similar to the nucleotides that make DNA, so they disrupt replication and cellular division. Unfortunately, they're not going to be selective to cancer cells because obviously all cells use nucleotides to divide. So we're going to have side effects that are related to your healthy cells, specifically your bone marrow cells. So by and large, most antimetabolites cause myelosuppression because they're inhibiting cellular division by mimicking these nucleotides. So here's just my own way of kind of graphically putting on where these work. So methotrexate is a dihydrofolate reductase inhibitor, which we'll see in the future slide. Then you have purine and pyrimidine antimetabolites that inhibit the formation of DNA in those ways. So let's look at these more in chart form. So I want you to know which drugs are antimetabolites. Which ones are pyrimidine or purine, I don't really care, but you need to know that they're all antimetabolites. And again, class effect being myelosuppression is an important point based on how they function. Some other key drug-specific side effects, as I go through these, I'm highlighting the most important or class effects. Obviously, all these drugs have other side effects I'm not talking about. These are the ones I want you to know because they're key, most common, or most important. So that's why they're listed here. And again, all the other lectures have their input into this. So if you look up all these drugs, you're going to get a laundry list of side effects. We're telling you what we think are the most important, and that's what's testable. So 5-fluorouracil and capecitabine cause a lot of diarrhea. Cytarabine at high doses can cause cerebellar neurotoxicity and ocular toxicity. Your purine, so 6-mercaptopurine can cause rash and photosensitivity. This is actually an oral agent. And fludarabine also causes a lot of immunosuppression because it does affect your T cells quite specifically. And then the antifolate, antimetabolite, methotrexate, as I mentioned, inhibits dihydrofolate reductase to deplete your folic acid pool. And unfortunately, the side effects from this are pretty broad. But mucositis and renal and hepatic dysfunction are the most common and dose-limiting issues we have to think about. So here's just a graphic representation of how methotrexate works. You need folate vitamins as a cofactor in DNA synthesis. And so by inhibiting dihydrofolate reductase, we can therefore inhibit the ability of the cells to kind of continue to proliferate by depleting these folate stores. As I mentioned, all of the antimetabolites, including the antifolates, also impact healthy cells. So how can we help patients on methotrexate? We can provide what's called leucovorin rescue, and leucovorin is a folic acid kind of mimic. Fortunately, healthy cells preferentially take up leucovorin, and cancer cells preferentially take up methotrexate, which is a very nice thing for us. So we provide leucovorin rescue that really repletes that folic acid in your healthy cells preferentially to overcome the toxicity of methotrexate. So anybody getting methotrexate is going to get leucovorin rescue. We'll talk about this more in some of the disease state lectures, but that helps prevent some of the toxicity. Leucovorin does not remove methotrexate from the body. That is not what it does. You know, a lot of physicians that think leucovorin rescue is eliminating your methotrexate. It's not. It's preferentially helping your healthy cells overcome the toxicity. That's it. So that's an important point as well. So moving on to your microtubule targeting agents, these are your vingas, your taxanes, and then a couple of kind of random agents. But I want you to focus on the vingas and taxanes because they're much more commonly utilized. And these are easy to remember because your vingas are vincristine and blasting and venerelvine. Easy to kind of remember in your head. And then your taxanes are paclitaxel, docetaxel, and cabazitaxel. Again, people were nice when they made these drug names pretty similar, so you can remember them. So these can disrupt the microtubules and tubulin in kind of two different ways. So your taxanes disrupt disassembly of the microtubules, and your vingas disrupt the assembly. That's not really the most important point, but I just wanted you to realize that's kind of how their mechanisms are slightly different. What's more important about your microtubule agents are your class side effects. So the vingas have some specific class side effects you need to know. These are commonly prescribed agents. So your vingas can cause neurotoxicity, and this can be neuropathy and GI, which is constipation. And then a very important point about vingas is that they're fatal if given via the intrathecal route. You can never, ever, ever give these drugs intrathecally. It is universally fatal. This is important because over the past few years, some safety reports have come out. We used to dispense these drugs at their lower doses in syringes, and unfortunately, the same day people get vincristine in their regimen is the same day of the regimen they're going to get intrathecal chemotherapy with things like methotrexate or cytarabine. So you can see how nurses may, or physicians may mix up the syringes and they accidentally inject the vincristine instead of the methotrexate intrathecally, and that is universally fatal from very slow neurotoxicity. So now we've made recommendations that vingas should only ever be dispensed in mini bags for infusion, even though they're small doses and short infusions, because you don't want to have that mix up. So sometimes there's a logical administrative fix to a very important clinical problem. The taxanes are known to have hypersensitivity issues, and again, some neurotoxicity. So you can see that microtubule disrupting agents, neurotoxicity should always come to mind, because that is a class effect. So there are two different types of topoisomerase inhibitors. So there's topoisomerase 1 inhibitors. Topoisomerase 1 produces single-stranded DNA breaks, and topoisomerase 2 produces double-stranded breaks. So looking at our topoisomerase 1 inhibitors, this is topotecan and irinotecan. And our topoisomerase 2 inhibitors are our anthracyclines, which are all listed here, doxorubicin, idarubicin, and mitoxantrone, as well as etoposide. So you can see that the topoisomerase 1 inhibitors commonly cause diarrhea, and the topoisomerase 2 inhibitors cause some myelosuppression. And then it's important that anthracycline class effects are cardiotoxicity, nausea, vomiting, and alopecia, and etoposide class effect is nausea, vomiting, hypotension, and myelosuppression. Moving on to talk about our alkylating agents. So these bind to alkyl groups and cross-linking in our DNA strands that can inhibit the DNA replication process because the DNA now is kind of cross-linked and kind of disrupted from being able to undergo the normal mechanism. So these are non-cell cycle specific, so alkylating agents are non-cell cycle specific that cause cross-linked DNA. And the agents of note are busulfan, cis and carboplatin, cyclophosphamide, ifosfamide, and oxaliplatin. Unfortunately, the alkylating agents don't have similar type names to be able to easily remember them. That one just is going to be some rote memorization, unfortunately. Some of the drug-specific side effects for alkylating agents I want to point out. Cisplatin and carboplatin are known to cause a lot of nephrotoxicity. They also cause electrolyte wasting, a lot of nausea and vomiting, and neurotoxicity. These are commonly prescribed agents, and so I think that's one of the important ones to kind of keep in mind. Your cyclophosphamide and ifosfamide are known to cause what's called hemorrhagic cystitis, or bleeding from the bladder, and they can also cause secondary malignancies and infertility. And ifosfamide specifically is more commonly causing encephalopathy than cyclophosphamide, so that is something also notable. Now, oxaliplatin has some interesting toxicities. It not only can cause peripheral neuropathy, but it also causes what's called pharyngeal dysesthesias. So what does that mean? That means people are going to have difficulty with cold. So they have a cold-induced neuropathy in their hands, but also in their throat. So that means that they drink something something with ice or a milkshake or anything that's cold, they're gonna have spasms in their throat that's extremely painful, almost to the point where like they cannot breathe. And this can be a very intense feeling. So they have to be counseled and recommended to avoid all cold-based products. And this is not only just pharyngeal, but also the peripheral neuropathy is cold induced. So they can't reach into a freezer. They can't hold on to a cold beverage. They're going to have extreme painful neuropathy by touching and doing cold things. So that's something, I used to live up north, so we have to definitely counsel our patients about that in the wintertime when it's freezing. These people have to bundle up and put scarves over because breathing in cold air when you're outside and it's 20 degrees, they're literally going to feel like they can't breathe because they're having this pharyngeal dysesthesia. So it can be quite intense. I know living down here, we might not be experiencing that quite as much, but with cold beverages and things, it's important to counsel patients what to avoid, as well as to understand what's happening if it does happen, so they don't totally panic. Because you can imagine how that may feel for a patient experiencing it if they didn't know what was going to happen. So that's one that I think is really important from pharmacy counseling perspective. Then busulfan-specific toxicity that I would want you to know is the neurotoxicity and hepatotoxicity. Okay, so this chart goes through some of our miscellaneous agents that you may hear about in some future lectures. Some key points off of this, your IMID agents, thalidomide, lenalidomide, and pomalidomide. Many of you probably already know that these are pregnancy category X. They're highly teratogenic, so we have to do pregnancy testing. They have REMS programs. Anybody who works in a community or specialty pharmacy may already know this, you've seen this. That's really important for monitoring and making sure our patients understand what they have to undergo to avoid the significant teratogenicity that is basically bound to happen if you get pregnant on one of these medications. I already mentioned Atra, it's a retinoid, and it can cause differentiation syndrome. We're going to talk about that in our leukemia lecture very specifically because it's very important. And then there are some enzymes we can use for specific cancers like PEG asparaginase, but unfortunately they have a lot of toxicities like hypersensitivity reactions, pancreatitis, and cause bleeding and clotting. So they can be effective, they come with a lot of side effects. So those are just a couple of the key points off of this slide. So those are our cytotoxic chemotherapy agents. Things that either affect the cell cycle or non-cell cycle specific, but basically they're disrupting the cells and causing them to die off in one way or another. But we have a lot of other ways in which cancer, right, we talked about, can proliferate. So it can cause ARMA genes to be activated, it can downregulate tumor suppressor genes, it can evade the immune system. So how do we target those things? How do we target the cell cycle signaling outside of just normal replication and cell division, right? There's all these other processes within the cell that stimulate growth and division. So what can we do for those? So a lot of this is in the past 10 to 15 years. Understanding the signaling within cells from the receptors on the cell surface to what happens inside the cell and in the nucleus and with the immune system around the tumor bulk. So how can we affect all of these things? That's where our targeted immunotherapies come into play. So you can, at your leisure, look up all the various intracellular signaling pathways. There are some great charts online that are incredibly complex. And if you're a PhD student or a PhD laboratory pharmacist, they really get into this into the translational science and research division to figure out how do all of these proteins interact with each other, and what are all of these different cell surface markers signaling, and how can we intervene to stop what we want to stop or start what we want to start without having other toxicities in other cells. So that's really what the intracellular signaling pathways are all about. This is just, I gave a list of a couple of them and a very generic flowchart, just so you understand as we're talking about these. So some of our targeted agents are going to be the receptors, right? So a receptor on the surface of the specific cancer cell or that cellular type. So breast cancer cells may express a certain marker, like HER2, that can be abnormally activated in the cancer. Lymphoma cells can express CD20 or cluster differentiation 20 on their cell surface, whereas other cells don't express that marker. So cell surface markers that are specific to that tissue type or that cancer type, we can target and then turn off the proliferation signal or turn on the apoptotic signal, right? But in addition to what's on the cell surface, we also have whatever signaling happens after that. So those are the intracellular signaling that maybe our small molecules like our oral chemotherapy agents can inhibit those parts of the pathway. And then within the nucleus, obviously, there are different transduction factors and things that lead to the amplification of the cancer cells or can turn it off. So maybe we can impact within the nucleus as well. So as we talk about these various targeted agents and things, think about where we're talking about. We're talking about a cell surface marker, a transduction marker, or inside the nucleus. And then after this, we're going to talk about immunotherapy, which happens outside the cell, right? What's happening in interactions with the T cells, B cells, etc. So this is not all-inclusive. As I said, I'm not really going to go into the targeted agents much because we could spend a full 2-hour lecture on all of these. And a lot of them are in solid tumors, which is not my personal area of expertise. Some of them are in the heme malignancies, but a lot of the targeted agents are in solid tumors. The future lecturers are going to talk about these when it's relevant to their disease state, so you'll get more of it there. That's going to be more of the testable information at that point. So here is just a list. I'm not going to test you on this exam out of a lot of this. I just wanted you to see that there are various targets, a lot of drugs within each class, and they all have their own different set of toxicities. So this really isn't as testable this time, and in your future lectures it will be. So for example, our proteasome inhibitors we use in multiple myeloma as a class effect in neuropathy. We know that that's something that they cause. But overall, you'll get more of this in your future lectures. There are also endocrine therapies which we use for our breast cancer and our prostate cancer and things like that, which you'll get in those future lectures. But it should make sense that as we're activating or inactivating certain things within the endocrine system, we're going to get side effects that make sense, right? So your selective estrogen receptor modulators and your aromatase inhibitors, for example, for breast cancer, a lot of the side effects are hot flashes and increased risk of osteoporosis and thrombotic events, which are things you would expect from too much or too little of certain hormones. Just like we talk about with people who take or don't take supplements for menopause, or don't take oral contraceptives. So that should kind of be in line with what you already know from other areas. Again, I'm not going to, on this exam, test you out of all the details here, but I wanted to introduce the concept so that when